Hey, wait, we're talking about endometrium. Hi, everybody. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I'm joined by my fun and friendly co-host, Dr. Susan Hudson from Texas Fertility Center,
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas.
Hey guys. How's
How are you
it
guys
going?
doing? Going great. I've been seeing you guys. It's been a little while since we've recorded, and right before we started, we were talking a little bit about some of the books that you guys have read this summer. So, Carrie, tell me what books have you read this summer that you liked?
So my gift to myself when I go on vacation is I go to the library and I get a huge stack of books. And I feel like such a VIP when I go because I use the app and I select everything that I want and they pull everything for me and they put their nice little labels on them with my initials and my name on them. And I
Yeah,
go and I
I
get
didn't
this.
even know they would do that in the library. That's pretty cool.
That's pretty
Oh
cool.
yeah. I walk out with this huge ass pile of books and a grin on my face because I'm just like, I've got my books. So I'm reading a bunch of things. I'm reading American Gods by Neil Gaiman, and then Let's Pretend This Never Happened by Jenny Lawson. And what else? The Maid,
Are
which
these
is by
fiction, nonfiction, or
these are all mostly fiction or entertaining ones. The one by Jenny Lawson is a memoir, which as she says, it's mostly true. She is ridiculous. Like when I read her, I'm like, oh, there's somebody else who thinks like I do because she is all over the place, but they're logical progressions from one place to the other. They're just wild. And so those are my nonfiction, no, those are my fiction books. And then I've got a whole set about thinking fast and slow. And there's another one
I found
on
that to
quick
be
decision.
very boring. I guess I think slow because I couldn't get into that. I actually that was one of the books I've never listened through the end. I just couldn't.
Oh, really?
Yeah.
I relatively recently started that, so we'll see how far I get on
It's
that.
been a while ago, so maybe now if I read it, it'd be different, but it's been a while ago.
It's
It's
kind of an
cool.
eclectic collection.
So
So
I'm
Susan,
What do you
what have you
I'm
been
an
reading?
audiobook person because I'm in my car a whole lot. So the kind of last book I read just outside of I've been listening to the Bridgerton series, but outside of that, I listened to the Benevolent Society of Ill-Mannered Ladies, and
Ah,
it's cute. It's cute. It's kind of in that Regency era of Bridgerton and things like that. And the way they set up the book, there's definitely room for more, and it leaves you wanting more at the end. You're just like, oh, but I need to know more. I have to know what else is happening in the story. And so it's a fun read. So I would highly recommend that.
well, I didn't realize until I guess when I was in medical school, I never have been a big reader. And after medical school and residency, it took me a while to like get into reading. And really, it's more honestly, I don't actually read books as much as I listen to them on Audible. So that's really cool commuting back and forth from work. But I've found over time what I really like for whatever reason are like period pieces, like historical fiction. And
Mm-hmm.
so The Women is a historical fiction book about Vietnam. It's really good, really,
We're
really
about to
good.
read that in our book club.
I really like that a lot. And the same author, her name's Hannah. I can't remember her last name, but anyway, she also wrote The Nightingale, and that's about World War II. These French women in World War II and kind of what it was like living in occupied France with the Germans there. And so they're really good books. They're long books, but they're really, really good, really entertaining. So that's
I'm
what I've kind
excited.
of been listening to lately.
That's
Yeah.
next on my list.
Yeah, I think you'll like it.
Cool.
So today we're going to do a question episode and we're going to talk about endometrium, right? And
Yep. So all about the uterus and the endometrium. So that's kind of the key theme in these questions. So we'll start off with this one. Hi docs, love your show. It's a lifeline for me right now. Thank you for listening. My husband 39 and I 34 suffered a miscarriage at 11 and a half weeks, trisomy 21. Started IVF right away due to a Robertsonian translocation, no male factor. AMH, FSH, follicle count high for age, had 2 DNCs and a hysteroscopy to be ready for egg retrieval. HCG was not 0, and the saline sono showed some blockage, clot, necrotic tissue. I developed a cyst after the hysteroscopy, which delayed my retrieval. Started retrieval, ovaries were doing great. uterine lining not so good, only got to 5.6 millimeters. I only had
Mm.
one period before pregnancy. I had had an IUD and two after the DNC. No period before the stems. Just started after the cyst cleared. What are your thoughts on my thin lining? Is it recoverable?
Yes, I think it's recoverable. I think I've had a few patients over the years that sometimes it took a few months to kind of get the lining kind of, rehab or regrouped or thickened or whatever. But I think things that increase blood flow to the lining, things like aspirin can be helpful. Vitamin E may be helpful. It helps dilate the spiral arterioles. That may help a little bit. It may just take few months of just additional estrogen, cycling her with estrogen and progesterone to kind of thicken the lining up. And then ultimately for these patients, a lot of times for IVF cycles, sometimes I'll do pure FSH, much lower dosage than what you would use for IVF. But that for people that have really thin linings, that's the one thing that can kind of help is if you do FSH and let their own endogenous FSH thicken the lining. Sometimes it seems to work better than just if we give, either vaginal or oral or estrogen via patches.
Mhm. This is one where I think tincture of time is probably going to be the best thing for you, and that is oftentimes one of the worst things to say to a fertility patient because they've been waiting forever and ever on end. But it may just be letting a little more time pass, having a few more normal cycles that give you the opportunity to clear everything on its own.
And again, trying different kind of preparations. Sometimes if you're taking oral estrogen, you may need to try vaginal or
Which can
injectable
work
or
really well.
transdermal.
Vaginal can really
I
work.
love vaginal estrogen.
Mm-hmm. Yep.
It's amazing how well estrogen absorbs through the vagina.
Yep.
And that's kind of my first go-to. And then you may actually eventually need to have another look hysteroscopy, make sure we don't have any scar tissue from what's been happening. But I would definitely kind of give there should be more tricks in your REI's box on things that they can do to make the lining thicker. And I think there's definitely still hope.
Well, and if she hasn't gone through IVF yet, I don't know if she has or not to create embryos, but if she hadn't gone through IVF yet, she could still do that while they're, kind of working on the endometrium, get
Yeah.
embryos.
And
All
that actually may be helpful in some respects because she'll be getting whopping doses of FSH and have
Mm-hmm.
really high estrogen levels.
Yeah.
So there's an element of helping in that as well.
Yeah. All right, our next one. 36-year-old female, currently in IVF, initial HSG hysteroscopy and blood work all normal. Egg retrieval was great. AMH at 13, had 6 PGT tested normal embryos.
Mm.
Um, First fully medicated FET was canceled due to thin lining. Spotting on oral estrace. Doctor switched to estradiol, valerate, intramuscular injections. Lining was better at 6.8 and proceeded to
Mm.
transfer with medrol, aspirin, estrogen, and PIO. Resulted in a chemical. Prepping for a second FET and hysteroscopy revealed adhesions. I've never had a
Mm.
DNC or any type of uterine surgery. I will be undergoing an operative hysteroscopy to remove the adhesions, but I'm wondering how I got them and will my chances improve for a sticky second FET attempt? So I would say that, most of the time we find adhesions in people who have had, obviously instrumentation. There are infectious disease causes
Mhm.
of intrauterine adhesions. The most kind of the biggest one I think is tuberculosis. So, tuberculosis isn't exceptionally common in the United States, but it definitely is more common in some areas than others. Um, and so, I would say the most likely etiology is at some point you probably had some sort of infection in your uterus that probably caused those adhesions. I think the biggest thing is, again, we all get focused on that lining number. Is it 7.0 millimeters? Is it 8.0 millimeters? That type of thing. But there's actually really good evidence to say that that number is not as important as we all like to think it is, and more kind of probably the change in the actual structure of the endometrium is important. So obviously, you definitely need your hysteroscopy, but you know, kind of don't get too worried about, what that actual number is. Hopefully it goes from something thinner to something thicker and has a good structure.
I would think too, if she has an adhesion, number one, it may be just something that's like a blood clot that or blood that look like an adhesion. I would doubt that she'd have severe adhesion since her lining got to 6.8. That's really unusual for somebody to have bad Asherman's, bad adhesions if your lining gets to 6.8. So, I think certainly you need to have hysteroscopy and have somebody look at that. But I bet you if you have an adhesion, it's just a filmy little, no big deal, snippet and we're done. I really don't think it's going to be a big deal. And a lining of 6.8 is not bad. I mean, I have plenty of people that have gotten pregnant with linings of 6.8. So, hopefully this next time around, you'll have a better outcome.
Put a finer point on the thickness component of it, there's a concept of the delta that we talk about. So the change between where you start and where you end, because you can have a lining of 6.8. And if you're starting at 5 millimeters and you go to 6.8, that's less than 2 millimeters difference. Nobody's really excited about that. But if you're going from like 2 to 6.8, that's a decent change. I mean, in some respects, that's equivalent from going 5 to 9. And so that makes a difference. And I think the nature of the adhesions make a difference too, because filmy adhesions are very different than if you've got really thick, more concrete adhesions. I mean, it's kind of the difference between waving your hand through a bunch of spider webs to break them up versus trying to wave your hand through a burlap sack to break it up. Like, one of those things is going to work. The other is going to require a lot more work to get through it. And so those are things to think of. A hysteroscopy will solve a lot of that. And oftentimes, antibiotics can also make a huge difference there.
Absolutely. Good deal. All right. Our next one. I just started my IVF journey and I'm doing a saline ultrasound and find out that I have a intramural fibroid, 9 centimeters by 7.2 centimeters by 6.3 centimeters. I had a few removed in 2015, with the biggest being 10 centimeters. As I'm 43 years old and not wanting to waste too much time, can I move on to do an egg retrieval now before having to remove the fibroid, assuming I have to, before attempting any transfers?
These are fun Tetris questions because it's how do we fit all of the things that we need to do
in the shortest amount of time.
In the shortest amount of time, in the most logical order. And one of the biggest limitations to going ahead with a retrieval with a fibroid that big is, can your doc get to your ovaries? Because sometimes when you've got big old fibroids like that, they're pushing your ovaries up and beyond the reach of our needles. And so that's probably the most immediately limiting thing. And that'll
But
be
ask
something.
your doctor, because sometimes we have big uteruses and the ovaries
Yeah.
are just like, boom, right there. So it just depends
Mhm.
on your individual anatomy.
So
Yeah,
that's a big thing to think about. The other thing that you want to think about is waiting to do anything big and dramatic until you know you've got an embryo. And so my vote would be get the eggs out first, if it's technically possible, and get the embryos, because at 43, it's going to take probably more than once. And if you can avoid a big old surgery because that fibroid's otherwise not causing you any problems, maybe worthwhile to do that.
Yeah, the only exception to that, Carrie, would be just like if she was going to if she knew for sure one way or another she wants to be pregnant, carry a pregnancy, like even with the donor egg. But I agree, at 43, unfortunately, your chances are not that great of having a normal embryo. And like Carrie said, if it's not bothering you, there's no reason to have a second surgery. The one thing I would do, like Susan said, is have your doctor look at your ovaries. Not only do you have this big fibroid, but my experience, it's not so much the fibroids, but it's the first fibroid surgery that may be the bigger problem, that maybe the ovary got stuck somewhere during the first fibroid surgery and maybe inaccessible, like stuck to the back of the uterus or something like that. And, I would take that into consideration too, because if you now only have one ovary that's accessible and you're 43, that even decreases your chances further that they would have a normal embryo. So, just consider all those things as you move forward.
But generally, if you can't get your eggs first, get your eggs first.
Yeah,
Time is
absolutely.
not your friend.
That's right.
Absolutely. Okay. Our next one. Hello, I'm writing to ask your advice on what to do when you cannot seem to achieve a perfect trilaminar lining. Even when I'm trying to get when I'm getting thickness above 8 millimeters, should I still proceed with transfer? We only have 2 normal embryos, so I'm worried. My history: 4 years trying to conceive, both naturally and through 3 IVF transfers over those years. Diagnosed with stage 4 endo last year and had excision surgery. Lots of endo spots removed, including both fallopian tubes and endometrioma, lesions on my bowels. I was on norethindrone for 6 months post-surgery and then did hysteroscopy to remove polyps and some scar tissue. I'm now doing a transfer cycle with oral estrogen and 2 patches every 3 days. Thank you.
So I would think, you know, if your lining's thick, and did she give us a thickness, or she just said it was
Over
thick? Which I think that's really good. You know, with all the stuff you've been through, you may not have a perfect endometrium, but one thing I would think about doing is doing a receptiva assay. With your stage 4 endometriosis, you may have some inflammation in your cavity. And if you've listened to some of our previous episodes or know what receptiva is, it's an assay that looks at an inflammatory marker called BCL6, and it tends to correlate with people when they have endometriosis. And so I wouldn't worry so much about the way your endometrium looks if it's that thick. I mean, ideally, we'd like for it to be tri-layer, et cetera. But if you've tried once or twice and your endometrium just isn't going to be tri-layer or as tri-layer as you want it to be, I think the thickness is really good. But I would recommend doing a receptiva assay just because of your stage 4 endometriosis to help improve your chances since you only have 2 embryos.
I don't know that I would do a receptiva for no other reason than you already know you have endometriosis, and so maybe treat accordingly there. Um, I think some of this is worth a deeper dive with your RAI, because there's some people who have a beautiful, gorgeous trilaminar lining at some points, and then it all goes to hell. And there are other people who you just never see a really great lining.
Mhm.
Like, you get enough aspects of trilaminar and you can see the difference between what's trilaminar in them and what's
Mhm.
the opaque kind of like different style that represents post progesterone exposure. But I think what records you have and what pictures they've been able to see will really help guide what makes the most sense, because there are some people who they're just not ultrasound photogenic and you just don't get that really beautiful picture. And it doesn't mean that they can't carry a pregnancy and it's not going to work. It's just you have to know what you're likely to get from any one person. And so I think comparison to what you've seen in the past is probably really relevant here to know, okay, is this something where it goes from good to awful and there's a marked difference, or is it just not as clear and crisp as we would like, which may be okay.
And I think a long time ago, Carrie, I think you mentioned on a episode, and this was probably a couple years ago, that you were talking about sometimes you actually look at the uterus abdominally when you're trying to kind of discern that trilaminar stripe. Am I like remembering this correctly?
Are, and that is our routine MO. We always look both vaginally and abdominally,
Oh,
see what we can get. And there are times where you get that gorgeous trilaminar picture abdominally and you don't get it vaginally.
oh.
I have no good explanation for it other than it's just going through a different set of tissues and it can pick up the picture more clearly. Or maybe
Yeah.
it's just that I'm seeing what I want to see, but I haven't had any of that either.
Well, and to that end, with stage 4 endometriosis, it's kind of the rule rather than the exception that the uterus a lot of times is really retroverted because it's stuck because there's so much scarring in the cul-de-sac. And so a lot of times if the uterus is retroverted, you're never going to get a great picture on ultrasound. The sound waves have to go through some of the uterus to be able to see the endometrium. So it really may be more artifact of kind of the way
Position.
your uterus is inside your abdomen. Yeah, it may be that you really do have a pretty trilaminar endometrium, but we just can't see it because of the position of your uterus.
Very good. Good question. Good question. All right, our next one. Hello, thank you so much for all that you guys do and the fantastic knowledge that you share. I'm 26 years old, struggling with infertility for 2+ years, but just started working with an REI about 6 months ago. AMH 2.2, HSG shows tubes open with some irregularity, but ended up having multiple polyps just removed with hysteroscopy. Post hysteroscopy was diagnosed with complex endometrial hyperplasia that
Hmm.
was found within the polyps. Now on 10 milligrams per vara daily for 3 months, and we'll do a biopsy at the 3-month mark. Need to repeat biopsy at 6-month mark if first biopsy is cleared to go just to confirm. Question is this: would you recommend going straight to IVF post hyperplasia treatment or starting with IUI?
I would say go straight, go go pat, like they say in Monopoly, go past go, collect your $200, go straight to IVF. You don't want to mess around with complex hyperplasia. It's rare, but I've had patients that just recently had a patient that had recurrent complex hyperplasia, and her doctor, really GYN oncologist, really wanted to take her uterus out. So don't mess around. If you have a borderline tumor of the ovary, if you have something like this, you need to get pregnant ASAP, because you just don't know. Hopefully this is not going to happen, but as doctors, we have to think about worst case scenario. Worst case scenario would be if you kind of do IUI, that's less expensive, less involved, less successful, and then it returns, and then all of a sudden your back's against the wall and you have to do something a lot more extreme. So I would say my vote would be go to IVF quickly.
With that being said, I mean, if you financially can't afford IVF and you want to spend 1, 2, 3 months doing IUI, I think that's probably reasonable, especially if you're not wanting to necessarily have multiple children. And so I think there is some discussion in there, but I think especially if you're thinking about having multiple children, doing what you can do to make your success rates as high as possible, as quickly as possible, is really important in your situation.
Hmm. I feel like this has been the theme of my clinic for the last 2 months, and I don't know why. And things come in waves, and I don't know if you guys find this too, but
I've had 2 people lately. Yeah.
yeah, I've had like 4 or 5 over the last 2 months, plus another friend, and just like, this is ridiculous. I'm ready to be on a different wave. If I could be on a wave of, everybody getting pregnant just from talking to me, I that's the wave that I want.
Those are the best.
Me too. Me too.
Yeah.
All right, our next one. Hello, we've been trying to conceive since 2018, so 6 years.
Mm.
Um, First transfer, all testing came back normal for me. Husband was diagnosed with male factor because of a varicocele. We have since been treated and his numbers have improved. But after the first round of IVF, we did an HSG and everything looked normal. We're gearing up to start an FET and found a couple of polyps. I've always had spotting between periods and was told it could be normal, and all my hormone levels were normal. Aside from male factor, we have been told we have unexplained infertility. Can polyps be a cause for why we have not conceived? I have since had a polypectomy and DNC, we have decided to try naturally for a couple of cycles. I would say this greatly depends on how much you had. Okay. And so there are times that we'll go and do a hysteroscopy and there are polyps there and we take care of them, but we're like, like this may have been a contributing factor. This probably wasn't like
Mhm.
the reason you did not get pregnant. And then there's other times we put in that hysteroscope and we're like, oh my goodness, there's no way that a pregnancy was ever going to happen in this place. And it's not that like one or the other is polyps or isn't polyps. It's just there's a gestalt of what we know the uterus is supposed to look like, and sometimes it's like, it's relatively close to normal, but we're gonna do a little housekeeping and make it
Mhm.
perfect. Versus there's other times that the entire uterus is overcome with polyps, and we're sitting there going, please, please, please let this not be any bad pathology. And I know we all have those moments. And so I
Mhm.
think that's the big question to ask your REI. Was it like, there were some polyps, maybe a contributing factor, but probably not like the thing, versus, wow, this was a uterus full of polyp.
Yeah, the one thing I would look at though is her time frame. Like you mentioned, she has been trying to get pregnant since 2018, and
Mhm.
maybe there were polyps there since 2018, but that seems like a long time to have polyps. And maybe she had some then and she has more now. And I would agree with you, there's definitely degrees. Sometimes you scope somebody and you think, gosh, I probably didn't really need to scope this person. There's not really much here. And then other times you're like, oh my gosh, this is why she's not getting pregnant. And so it's hard to say. And, honestly, you may never know the answer to that question. But as Carrie says, a lot of times, you don't want to keep seeing your doctor. You want to do something that's going to help you get pregnant. So more importantly, I think it's good that you're moving toward treatment sooner rather than later.
Mhm. I would agree with all of those things. Size matters. If it's everywhere all over the place, that's much more of a big issue if it's just one or two itty bitty ones. And then micropolyps are also something to consider because they are not big and they don't have that really impressive appearance of, the house that totally needs to be renovated from top to bottom. But it's enough of those little things that look abnormal where you're just seeing
Mhm.
those itty bitty micropolyps everywhere where you're like, okay,
Mhm.
this the structure looks normal here, but this is not normal. There's something else going on. So
That's
things to
always
think about.
another reason why I think it's a lot of times, not a lot of times, but we occasionally have people who are like, oh, I'm just going to have my OB-GYN do my hysteroscopy. And although OB-GYNs are absolutely trained in doing hysteroscopies, when we're sitting there looking with a critical eye of your endometrium, I think it's a different eye than the one that you're getting with your OB-GYN. So I encourage you that if you do need to have a polypectomy, to consider having your REI do it, just because there are nuances that we notice that may not be picked up and that aren't going to be conveyed through an operative note or even necessarily a picture, which transferring pictures is never a
Yeah.
easy
It's never the
straight
same as
line.
being there
It's not the
yourself.
same as being there. So those are just some additional tidbits. All right. Let's see. Here's another one. Fluid development after starting estrogen for FET. How often can progesterone make this go away? Anything that can be done to make this go away? Hysteroscopy was done a week prior to starting medications.
So progesterone will oftentimes make it go away, but not always. Your history is something to think about here, because if you're someone who's had a ton of surgeries where there's been a lot of action there, think myomectomies, C-sections, hysteroscopies where they've had to take down serious amounts of scar tissue, then that's more likely to be kind of a serous fluid that may be less normal, that probably needs to go away before you do this. There's also some uteri where it looks like it's probably just more mucus, more normal that's in there, and the proj will make that go away pretty readily. The other thing to think about is how high are your estrogen levels, because there are some people where you give them a dose and their levels are pretty physiologic, meaning what your body does normally. There are other people that you give that exact same dose to and their levels are absolutely sky high. And so depending on which of those categories you fall into, you may be someone who just needs a dose that is really pulled back from
Slower dose.
maybe what your REI is like used to giving, or what we think you should get, that, okay, we got to adjust that. And different protocols can really help too. So maybe a modified natural cycle with letrozole instead of estrace, just messing around with different things to see what works for you.
Yeah, and one of the things, she may have mentioned this, but I'm certain probably her OB would, or GYN or REI would have looked at her tubes by now. But certainly if you have a blocked dilated tube, fluid can leak back into the uterine cavity. And as Carrie mentioned, if you've had a previous C-section, sometimes fluid can be captured in that C-section scar and it can leak back, and it can also cause fluid in your cavity. And that's kind of a challenging problem to fix if that's the case.
But kind of back to the original question, like if I just have fluid in the lining of the uterus, what are the chances of the progesterone taking care of it? I would say 80+% of the time it probably is.
I
I
would too.
usually have
Yeah.
patients come in for a scan the day before embryo transfer, and inevitably they're like, ew, I had like this huge amount of discharge.
Yeah. Yeah.
Just kind of squeezes it out and it ends up being fine. So people do get very worried about fluid, and there are times that fluid is persnickety and troublesome and that type of thing. But the general rule of thumb is most fluid is going to go away on its own.
I saw a study that looked at it, and it wasn't huge, but it said that there's really no difference if you aspirate the fluid out and then put the embryo in. Like, success rates weren't all that different.
We've done that before, particularly if
Yeah.
it's been somebody that's had fluid in their lining and then they come back again and we do some of those things and nothing changes. Well, a lot of times we'll go in and aspirate the fluid, and we definitely had some pregnancies with that. But you're right, you kind of hate to do that if you'd rather not have fluid at all if you can help.
Yeah, avoid it.
Yeah.
Absolutely. Y'all want to do one more?
Okay.
Okay, and this one is a good one because it has to deal with the cervix, which is part of the uterus. And I think we're asked this a whole lot. Hello, I'm 37. My husband and I have been trying to conceive for a couple of months. Recently saw my OB-GYN for my pap smear. She tested me for HPV and was surprised to learn that I test positive for high-risk HPV 18. Does an HPV diagnosis affect fertility and or subsequent pregnancy? Thank you. I love that question. It's a good one.
It's a good one. So
what do we think?
So probably the biggest way that this relates is that we don't want you to have cervical cancer while you're in the midst of fertility treatment or being pregnant or any of those things. Because while you can do colposcopy to take a look at the cervix, you could even potentially do the tiny punch biopsies or pinch biopsies. You can't do a leap. You can't do anything that's really excisional that could be curative or heavily treated. And we don't want you to go for 9 months untreated with active cervical cancer. And so I would say get whatever you need to have treated, and make sure you're doing the monitoring so that anything you need to do, you can. But a lot of times, no, if you haven't had it progress onto cervical cancer, then, it's there, but it doesn't
It's
have a
not going
huge.
to hurt your chances of getting pregnant, and it's not going to hurt your baby. Our biggest thing, as Carrie said, is we don't want you to have to make a choice between your safety, health, and well-being and that of the baby. So we want to make sure all testing, monitoring, that type of thing, that we have the blessing from your OB-GYN, that it's a good idea to start trying again.
Well, and the way we do pap smears and the way we do testing for abnormal pap smears has changed over the years. But I would think this would be somebody you might want to think about having colposcopy and maybe a biopsy sooner rather than later. There's a time there where everybody got all that stuff done. And then there's now a time where we feel like, well, your immune system may get rid of this after 6 months or a year or whatever. Well, if you're trying to get pregnant, particularly if you have a high risk HPV type, you may want to think about being a little bit more proactive. Certainly talk to your OB/GYN to make sure they agree, but maybe you do want to come in and have colposcopy, which is where they look with a microscope kind of at your cervix and do biopsies on areas that potentially could be problematic. Because like Carrie said, when you're pregnant, if you do one of those biopsies, it's just there's so much blood supply that goes to the uterus. It's really bloody. It's really hard to do. It's hard to see. But more importantly, you can't treat it if you're pregnant. So it's much better to find out if it's real, if it's a problem now, I would think. And maybe she even just looks with the colposcopy and doesn't do any biopsies, but at least just make sure there's not something there that's really obviously abnormal now rather than waiting 6 months or a year, particularly since you're 37 and you want to get moving and try and get pregnant sooner rather than later.
Fantastic.
All right. Well, this has been a great episode. So, to our audience, thanks for listening. Tune in next week for more. Be sure to subscribe and leave us a review in iTunes. We'd love to hear from you. You can also follow us on Instagram and Facebook. So, hop on and leave us a like or a comment.
You can also visit fertilitydocsuncensored.com to submit specific questions about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.